Good evening, everybody. My name is Dr. Gigi from the Rodham Institute, which is housed at the GW School of Medicine and Health Sciences, where we are dedicated to improving health equity in Washington, D.C. by catalyzing, connecting, and convening. I'd like to welcome you to this wonderful new webinar about multiple sclerosis. But before I introduce our guests, and we've got two wonderful guests, I'm really looking forward to a robust discussion on this important topic. Let me tell you what's been going on with COVID. First of all, COVID in the Washington, D.C. area, we've been getting more vaccines. And hopefully within the next couple of weeks, we'll get many, many more vaccines. The Johnson & Johnson vaccine has now become available in the District of Columbia. So we have 3 vaccines. We've got the Moderna, we've got the Pfizer, and we've got the Johnson & Johnson. We've got on our resource site at the Rodham Institute, you can look up some more information. But also, the Rodham Institute is a member of the steering committee for the Black Coalition Against COVID. And I have to tell you, it's an excellent website. So if you go to blackcoalitionagainstcovid.org, you can get a lot of your questions answered. But just as a quick reminder, the Johnson & Johnson shot is 1 dose, whereas the Moderna and Pfizer are 2 doses. I would really urge you to think about getting vaccinated because getting COVID, even if you don't die from it, is no joke in that as somebody who takes care of patients both in the inpatient setting and the outpatient setting, people get very, very sick. They can die, of course, and that's the ultimate, right? But also they can get stroke, they can get heart attacks, kidney disease, of course, lung disease. Actually, one of my colleagues' mom just lost part of her leg. And then there's the long hauler syndrome where you can't focus, can't think, feel fatigue, can't breathe, chest pain. So death is not the only thing that can happen from COVID. Please think very seriously about getting the vaccine. And I'd like to also tell you that the Rodham Institute will be partnering with all of the academic institutions in the District of Columbia, which includes Howard and Georgetown and Children's, also includes the health systems of MedStar and United Medical Center, to not only bring the vaccine to Ward 8, but to bring those wraparound services that people are so badly needing, mental health, as well as food, as well as just re-engaging people into care. So that's what sort of the Rodham Institute has been up to. We've also just finished distributing 560,000 masks and hand sanitizers to mostly Southeast Washington, D.C., but throughout the District of Columbia. So we're very proud of that work. Somebody very generous gave us, he had a surplus of these masks and hand sanitizers and just donated them to us. So we thank Mr. Kim very much for that. So without further ado, I'd like to introduce my 2 guests, Dr. Rothstein and Dr. Williams. And so I'm not very good at, reading biographies. I think it's just a lot more interesting to ask the question. And I'll start with you, Dr. Rothstein. Can you tell us a little bit about yourself, including where did you grow up and why did you get interested in multiple sclerosis?
Well, I grew up in Brooklyn, New York, and you probably can tell that from my accent. How I got, let me just point out that I am the director of the Multiple Sclerosis Clinical Care and Research Center here at George Washington University. I've been at George Washington University for the past 17 years, but prior to that, I was in practice of neurology in Seattle, Washington, which happens to have the 3rd highest prevalence of MS in the country. And so you could not possibly be a clinical neurologist in Seattle without having a large number of MS patients. So when the opportunity came for there be a neurologist in our program with familiarity with MS, I was picked to take over that program. And I must tell you that it's one of the great satisfactions in my life to be able to manage MS patients, because for years and years in practice in Seattle, I had no MRI available. And so the diagnosis was exceedingly difficult. In fact, I remember we had sort of a hot tub in our clinic, and you would put a patient that was suspected of having MS in the hot tub. And if they couldn't get out, that was MS. We
Wow.
made a lot of mistaken diagnoses over the years. Also, for many years of my practice, we did not have effective treatments for MS. And so patients often became paralyzed, they could become demented, and they could die of their disease. And the situation is totally different now. We have 20 different medications, which are disease modifying therapies, which work and change the course of the condition. And it's
Mhm.
an exciting time to be involved in MS. So I am very pleased to be able to do that.
Thank you so much, Dr. Rothstein. It's really a pleasure to have you. And yes, that historical perspective, because I'm of a certain age as well. And I grew up in Michigan, and we'll talk about why that's relevant in terms of MS diagnoses. But and I remember too that when you had a diagnosis of MS, it was just people, it was one of those things almost like cancer. People didn't even want to mention it, and very frustrating. But a lot has changed, hasn't it, Dr. Williams? And I would love,
Absolutely.
first of all, welcome. We're so delighted to have you. Before you answer that question, though, tell us about you. Where did you grow up? Tell us, why did you get interested in this field?
Yeah, thank you so much for that question. And thank you so much for having me, Dr. Gigi. So I was born in Chicago, but I
Oh,
grew up in Atlanta. So I consider myself a Georgia peach. Please don't tell my mother, she would be appalled. Um, but I grew up in Atlanta, and I got interested in neurology very young. When I was, in school, I was always very interested in the brain, and I wound up working in the field of MS because I had an amazing mentor. Dr.
mm,
Mary Hughes was my mentor and an MS specialist in Augusta, where I did my residency training. And I loved the comprehensive care that was provided. I loved being a part of the journey with people. Subsequently, I had a cousin right before I started my training who was diagnosed with MS. And so
mm.
that furthered my interest in working with people who have MS. And I came along a little bit further along the spectrum than Dr. Rothstein. So there were a couple of therapies, but certainly I've also seen a great transformation in the field and our ability to help people and really change the natural history of MS. So it's been very exciting and very encouraging to be in this
Mhm.
field right now.
So, Dr. Williams, what is your official title? Where do you work? Can you tell us?
Yes, absolutely. So I'm in Atlanta. I work as a medical director of Joy Life Wellness MS Center, a practice that I started several years ago. So prior to that, I was a medical director at the Augusta MS Center at the Medical College of Georgia, and also spent nearly 10 years working at a large private practice MS center. So I
Mhm.
struck out on my own a couple of years ago.
Well, we are delighted that you're with us. And let me just ask you the first question, because I think the stereotypical patient, when I was actually doing my medical school and my training, was usually a white woman, and she was in a wheelchair, and really just, it was usually somebody younger. And, as Dr. Rothstein alluded to, as physicians, as clinicians, we felt very helpless. But you mentioned your cousin. Can you tell us sort of who is the typical patient with MS?
Yeah, so it differs from place to place, right? But here in the US, there's a bit of a different profile than what we see overall. So I also in school was taught that MS was a young white woman's disease. People were certainly very disabled as well. What we found in recent years is that there's been data published over the past 10 years that suggests that here in the US, the incidence of MS as well as the risk for MS is highest in Black people, which is
Mhm.
very contrary to what most of us have been taught and what many people have been thinking. And so it's very surprising. Obviously, I live in the South. And so when I would go look in my lobby, the people in my waiting room didn't look like the people that I heard about in our textbook. So half of my lobby was Black women with MS. And even when I moved to Atlanta, maybe 40% of the folks in our practice, and we had 8 providers in our practice, so it wasn't just me that was attracting a certain patient group, but 40% of the folks in our waiting room were African American. And so I think that that knowledge is changing over time. And there's a lot that we're learning about risk. There's a lot that we're learning about social determinants of health. But I think that this group is especially important because from the research we have, we see that the outcomes are poorer, as with many of our disease states, right? And so I think that there's a lot that we need to learn and understand about why the risk is increased and why we're seeing more severe outcomes in African Americans particularly.
So Dr. Rothstein, we mentioned MS, which is multiple sclerosis. Can you tell us a little bit about, what actually is the disease and maybe how it presents clinically, what some of the symptoms are?
So MS is a chronic inflammatory and immunological disease, which targets the myelin, which is the insulation that protects the nerve cells. So this is what we call a demyelinating disease. It's myelin that surrounds and protects nerve cells. So when that becomes damaged, whatever function that set of nerve cells has is going to be impaired. And MS is very important because of it now is known that there are over 900,000 patients in this country with MS. And that was a statistic developed by Dr. Whalen at our local Veterans Hospital. And it's because of its chronicity, its tendency to induce disability, and most importantly, it does affect, for the most part, young patients. The peak age of incidence is between 15 and 45. So unlike most of the other degenerative neurological conditions like Parkinson's and Alzheimer's, which affects older populations, this is a young person's disease, and it means there's chronicity. These patients have this condition for 30, 40, 50 years. And so they become very, very attached to their clinician who has to manage the ups and downs of their disease. And it's important to know that MS has changed dramatically in the last a couple of decades. Imagine what it was like to try and diagnose MS, as I've said before, the advent of MRI. And there was nothing you could do for patients. And now we have 20 MS therapies, and some are even on the way. So we're going to have a lot more to work with in the coming years. As far as the signs and symptoms, it really depends on what part of the brain is affected, or spinal cord. If the hemispheres are damaged by MS plaque, patients might have weakness or numbness. They might have cognitive impairment. They might have fatigue. If the brainstem is involved, patients might have vertigo. They may have double vision. They may have problems with speech. And again, if the cerebellum, the part in the back of the brain that controls movement, tremor and incoordination or ataxia occurs. And spinal cord dysfunction is associated with weakness and numbness, but also bladder complaints. And patients sometimes will experience shock-like sensations when they move their neck. And the eyes can be involved. In fact, about 16% of MS patients present with optic neuritis, and they will lose a part or all of their vision in the affected eye, and it will cause a lot of pain on eye movement. So those are usually the kinds of symptoms that bring patients to their clinician or to their neurologist to try and understand what it is that is the source of their symptoms. Well,
yeah, Dr. Will, thank you for that. So just sort of for, just to review, so you've got your brain, and then you've got the spinal cord, and then you've got the different nerves that allow us to move our arms and our legs. So really depending on what part of the nervous system is affected, where that multiple sclerosis is, and it's like the wire, it's like a frayed wire, right? So that the you can't actually, that plug doesn't work, right? So that if it's about moving your hands, then you can't move your hand. If it has to do with your vision, then you can't see. If it's about your, the part that regulates your balance, then you can be at risk for falling, right? So, so Dr. Williams, I mean, you that's sort of your practice, and we talked about some of the neurologic signs, and sort of what do you see in your practice? And is there anything else besides the numbness, the tingling, the weakness, the unsteadiness, or difficulty urinating that you see that's not actually part of the nervous system? What do you see?
So, so there are some symptoms of MS that are a little bit more elusive. They're related to the nervous system, but not necessarily as hardwired as, let's say, movement. Some of the more disabling symptoms, or what we call silent symptoms of MS, can include fatigue, which can be very overwhelming, right? And there's not a particular part of the brain where we can say a spot in this area will make you have fatigue, but many people actually have to leave the workforce because the fatigue can be so severe. Also, we see a lot of cognitive dysfunction or difficulty with thinking. And that can be from accumulation of lesions over time, accumulation of these spots and these areas of damage in the brain. And so often that's a reason some people may have difficulty performing their work, difficulty doing their household duties. It may not get to the extent where they have dementia or symptoms that are like dementia, so to speak, but certainly can very much interfere with their daily function. So those are some of the more nebulous symptoms that we see that are related to damage to the brain, but not quite as concrete. And I think the other thing to point out is that symptoms of MS are very typical of other conditions, which is why sometimes it may be misdiagnosed. If you see a young person who has numbness in their arm, or they have, let's say, pain in their back or numbness in their leg, they may go to the ER, and that person, who sees them may say, hey, this is a pinched nerve, and the symptoms go away. And that's the difficult part. People may have symptoms that come on for a short period of time, several weeks, several days, and they go away. And then you may not seek medical attention, and you're still developing damage to those nerves over time during that time that you're not being treated for MS. So that's why it's so important, if you know something is wrong, to seek that medical attention to get a diagnosis.
Well, and when I was in medical school, they would say that you would have symptoms that are separated in time and space. So it may be, as you said, that you have something, with numbness in your leg, and then it'll go away. And then you'll have an eye complaint, a year or 10 years or some period of time afterwards. But it's not usually the same place coming back repeatedly. But yeah, I think the challenge is this, is that, a mom who is carrying her baby, and maybe it's a newborn, and she's not sleeping very well, comes in with fatigue and numbness in her arm. Well, exactly as you said, is, oh, you're not sleeping enough. So things get attributed for other reasons. And I think a couple of things. I think, we can sometimes be more dismissive of certain populations more than others. We know that that's true of women in general, and certainly communities of color, number two. But as you mentioned, Dr. Williams, these symptoms, sometimes they can be so nonspecific. Fatigue, right? A lot of people have that, not being able to focus or concentrate, especially in the era of COVID, right?
Right.
And sort of the mental health issues that also can make it confusing, right? So what are the risk factors, Dr. Rothstein, for MS? Is there a certain group that is more susceptible? What makes people, and is there something that can be done to prevent the development of MS?
I'm not sure that there is any technique that we can recommend that prevents MS. For most part, patients who develop MS probably have genetic factors maybe contributing. It may be exposure to certain viruses. There's been a lot of speculation that the Epstein-Barr virus might be implicated, and there may be a vulnerability that's genetically determined. The reason Epstein-Barr is implicated, it's very interesting. As you go either north or south of the equator, the prevalence of MS increases dramatically. So having done my residency in Seattle and having practiced for years there, as I mentioned, it's the third highest prevalence in the country. Washington State, Minnesota, and New Hampshire and Southern Canada have much higher rates of MS than does, say, the Southern United States or Central America or Africa for that matter. Northern Europe has a much higher prevalence than does Southern Europe. And the same goes true as you go south of the border, south of the equator. New Zealand and Australia have a much higher rate of MS than, say, South America. And Epstein-Barr has the same distribution. It tends to like colder climates, and it's almost unknown at the equator. And a very, very high percentage of MS patients have antibodies to Epstein-Barr. So that may be one risk factor. Another risk factor is women. 70% of relapsing form of MS, which is the most common form, where patients have attacks from which they often recover. They may not get back to their baseline after several attacks, and so they wind up with some degree of disability. But women represent 70% of the relapsing remitting population. And I agree with Dr. Williams that there is a definite increased risk among African Americans. This hasn't always been appreciated. In fact, if you look at the textbooks, it's thought to be a Caucasian disease of young women. But certainly in my practice here at GW, the vast majority of my patients are African Americans, especially African American women. By contrast, there's a relatively small population of Blacks in Seattle, but half of my MS patients in Seattle were African Americans.
Wow.
I think being Black is another risk factor. I should mention too, there's another form of MS that I want to just touch on. It's called primary progressive MS. This is a condition where there is no attack. It's an insidious progressive disease that affects mostly motor function and cognitive function because it is primarily a gray matter disease of the brain and spinal cord. And it's been very difficult to make the diagnosis of primary progressive MS because we don't really have a very good way with standard MRI to see what's happening in the gray matter.
Mm-hmm.
White matter lesions show up readily because there's a lot of inflammation, and inflammation shows up as bright spots on the MRI. But we've been working actually here at GW with a technique that involves a three-dimensional voxel-based morphometry, is what it's called. And this defines a whole host of gray matter structures. And it's important to realize that this is a gray matter disease as well as a white matter disease.
And can you tell us what is the difference between gray and white? Because maybe the audience, not everybody knows what that is. What's the difference?
Gray matter is where the nerve cell bodies are in the cortex, in the deep nuclei, structures like the thalamus and the hippocampus. These are gray matter structures. And it turns out that only 5% or so of gray matter lesions that can be found by histopathology are actually seen on MRI. But using these advanced MRI techniques to define gray matter, we have learned a great deal. And it turns out that gray matter lesions are much closely aligned with the patient's disability and fatigue and cognitive impairment than is true in the white matter. And so we have come to recognize there's a disconnect between what you see on a standard MRI and what is actually going on with the patient with all these other factors.
Yeah.
I like to
Well,
describe it like an MRI is like a mirror or a magnifying glass, and there's a certain level of detail you can see when you look in your bathroom mirror versus when you go to one of those nice hotels that have the 10 times magnification mirror. And so the techniques we have now are like looking in that bathroom mirror, but the techniques that Dr. Rothstein and his colleagues are working on are hopefully those ones where we can get much more detail so we can see what's going on under the surface.
So, was mentioned, Dr. Rothstein, that in Africa, the prevalence or the incidence of MS is a lot lower. And yet in people of African descent, in the African diaspora here in the United States, the rates are higher, significantly higher. And Dr. Williams, you had talked about the structural and social determinants of health. Dr. Rothstein, you talked about genetics. I think sometimes people think about the gene as just being on, off, and that's it. But what we've learned is that the environmental, the stress, the food, the occupation, what we may be exposed to in terms of the kind of work that we do, along with our genes that give us a predisposition, all of these things interacting, and maybe a virus comes along and kind of tips us over. But, Dr. Williams, can you tell us, because you mentioned the structural and social determinants of health playing a role?
Yeah, so there's a lot of interest in the prevalence of MS in Africa. So there have only been a couple of published studies, and I usually update myself every year about them. And there's not been a lot of literature published. However, some of the characteristics that we see from cases published about MS in mostly South Africa, is where most of the literature has come from, is very similar to what we see in African Americans. So we see a prevalence of what we call optical spinal disease, meaning people have more vision problems, and they have more problems with lesions or damage to their spinal cord, which often affects the ability to walk and their motor function, use of their hands and legs, etc. And we also see more severe disease. So in those populations, you see more severe outcomes in terms of more disability earlier on. And you also see that here in the US. And I think the part that you talked about a few minutes ago is so key to understanding why there's such an increased risk here in the US. When we talk about the genetics of multiple sclerosis, it's very complex. If you think about a disease like sickle cell, if mom has a gene, dad has a gene, and we can predict 1 in 4 of the kids will have the condition. With MS, there are over 200 different genes that may be involved in increased risk. And when we try to break down what those genes actually do, we don't really know what a lot of the genes' actual function is. So it's much more complex, and certainly there's likely some environmental factor, that is also kind of tipping things over the edge. I think particularly for minority populations, I think that late diagnosis is a large part of why we see some of the outcomes that we're seeing, because you have to have it as a thought on your mind when someone's coming in with certain symptoms in order to diagnose it. And then I think that, again, those social determinants of health in terms of ability to, have access to healthcare, access to MS specialists, access to therapy, those type of things are affecting the outcome. But certainly the risk is very complex. And there are other things that are associated with increased risk, such as smoking, comorbidities such as obesity, so things that may preferentially affect populations or communities of color, or habits that may be more prevalent, are also kind of adding into that mix of the genetics plus environmental factors that may lead someone to be at higher risk for disease.
So, you mentioned obesity and some other conditions, and Dr. Rothstein, you had spoken about inflammation and sort of the antibodies being sort of directed, if you will, at or having an autoimmune component. People don't realize that when you are chunkier, the amount of inflammation in your body is actually higher. So that, I mean, it makes sense to me that MS would be higher, right? Because you just have more inflammatory markers that can also increase heart disease or diabetes. But do we know sort of, are there specific antibodies in the blood that we can test for to say, oh, this is the blood test that puts you at risk or that measures the severity of your MS, or we can follow it to see if you're responding to treatment?
I don't know that there are specific antibodies that have been identified for MS, but we do know that there is a definite immune relationship. And the evidence for that is, number one, when we do spinal fluid analysis, we find oligoclonal bands, which are in the spinal fluid to a much greater extent than they may exist in the blood. And that's an indication that the B cells, which are very important in conferring immunity, are involved. Further, there are treatments now which specifically go after and inhibit certain CD20, CD19s, which are a reflection of B cell activity. We also know the T cells, which are critical for immune responses, are definitely involved because most of the medicines that are currently available to treat MS in one way or another inhibit or influence or change the nature of the T cells. Some medicines, for example, sequester T cells in lymph glands so they can't get into the circulation, and therefore fewer T cells get into the brain to cause their damage. So the fact that you have T cells and B cells, which are critical parts of the immune system, are central in providing disease-modifying therapy and changing the course of the disease. That's the evidence we have that immunity is a key factor.
Right. So immunity is very important when we're protecting ourselves from different diseases, right? It's when it's over exuberant. And so, for example, now with the recent COVID, infection, we now have seen that sometimes the body's response to the COVID virus is actually what causes the problems. That's especially true among younger people. And it's the virus itself may be there, but how the body is responding to it can actually be very damaging. So, and the B cells and the T cells usually play a very good role, but like a lot of things in life, if it's too much, right, then it can actually be harmful. So Dr. Williams, talk to us a little bit about some of the common medications that you use, and maybe some of the side effects, but also how helpful they are, these different medicines.
Absolutely. So we have come a long way, as Dr. Rothstein has said, in terms of our ability to treat MS. And I think one of the things that I like to keep top of mind or in the forefront of my patients' minds is that one of the things that people often come into the office and say when they get diagnosed is that there's no cure. And so my response usually is, name 5 diseases that are curable. And there are crickets, right? So we manage MS just like we manage diabetes, like we manage hypertension. We manage, right? We don't generally cure these things. Now, some things can be improved with diet and exercise. MS, unfortunately, is not one of those conditions. So we have several different types of therapies, and I kind of put them in 3 categories very crudely. We have injectable therapies that you give yourself a shot, like, for instance, how people would give themselves a shot of insulin if they had diabetes. We have oral therapies or pills, which was a very exciting development. We had our first oral therapy in 2010, which was phenomenal. Everyone was very excited because we didn't have any pills for MS before then. And we also have several infusion therapies. So those are IV medicines where you generally have to go to a clinic or go to a center and receive some type of infusion and sit there for a couple of hours and be observed. So the medicines, I kind of crudely put them into category: shots, pills, and IVs. Some of the shots include things like interferons. That was the first medicine that came on the market for MS in 1993. Okay, and so we also have several medicines in that category, and we then have oral medications such as Tecfidera is a common one that's used. Fingolimod, there's several medications in that class that we use to treat MS, and those will be kind of moderate or middle efficacy effectiveness therapies. And then we have more of what we call our high efficacy therapies, which most of our infusions or IVs put into. The thing about MS is that it's very individualized. So each person is different. And I like to say, if I've seen one person with MS, I've seen one person with MS. And so the most important thing for people to do is sit down with their healthcare provider, come up with a plan that you feel like is best for you. For some people, a pill may fit better into their lifestyle. For some people, they're not afraid of injections. And so they say, hey, I'm fine doing an injection if I feel like this is the best safety profile. And other people, it may be more convenient for them to get infusions, or their disease may be severe enough where we feel like they need a very high efficacy therapy. But I think the main things that we're concerned about, are making sure that we're treating the MS. So with our injectables, people can, of course, have injection site reactions. With our oral medications, the side effects differ. Some people may have stomach upset with some of the medicines. Other side effects could include slowing of the heart rate. So there may be some monitoring that may be required. With some of our infusion therapies, there may be a small risk of possible malignancy or cancer, or there may be other infections that people can have. Because when we're trying to treat MS, we're trying to decrease the immune response. So basically, your immune system is doing the most, and we're trying to slow that down. And the more effective we are at slowing that down, when we start to kill or deplete cells, potentially the more severe side effects we could run into. And so I kind of explain it that way, but certainly there are many options, and our conversation gets longer and longer every year as we have more treatments available. But it's a good thing, because I generally tell folks we can find something that will treat your MS that you can tolerate. And so we try to keep working until we find that thing.
Well, thank you. Dr. Rothstein, I have a question for you, and then we'll take some of the questions that have come through the chat. There are some very good questions indeed. So do these medicines, do they prevent future MS, lesions from developing in the brain, or are they helping to treat the symptoms that a person has, or both?
So there are very good statistics on the different classes of medicine that Dr. Williams outlined. The older medicines, medicines like Copaxone and Betaseron and Rebif, and these were injectable medicines. They reduce the risk of having additional attacks by about 29%. The oral medicines reduce the risk of relapse by somewhere around 54%. The infusions, medicines like Tysabri and Ocrevus, they reduce the risk of relapse somewhere around 67 to 75%.
Oh, wow, that's a lot.
Ocrevus is the one and only medicine that has been proven to be effective in the primary progressive form of the disease. All of the other medicines are used for relapsing, remitting disease. They all tend to lower the number of new lesions. They all, most importantly, at 5 years, have patients treated with disease-modifying therapies have less disability than placebos. In those days when you could actually use placebos, it's now considered unethical to have trials with placebos, because all of these medicines have had a very beneficial effect for the patient. And there's one other thing I'll point out. Prior to the era of disease-modifying therapies, patients could develop a condition called secondary progressive MS. These are patients who for 15 years may have had typical relapsing remitting disease, and then they evolve into another condition which is very much like primary progressive disease, where they either do not have relapses, or if they have a relapse, it's very rare, but they just have this progressive and exorable worsening of their gait. They can have cognitive issues. They have more and more fatigue. So this is much more like a gray matter involvement instead of just involving white matter and a few gray matter lesions. So there's been a dramatic change. In fact, I would say, and I don't think there's a lot of argument, that probably the most significant breakthrough in the last 20 years in neurology has been the management of multiple sclerosis. I think
Wow.
great therapeutic wonder that we have so many medicines at our disposal. And it's a very exciting time to be a neurologist who deals with MS.
Yeah. Well, there's actually a question from Ms. Lindsay Pearson, and I'll read it. It says, my mother-in-law has MS. We are seeing her deteriorate pretty rapidly. As I understand it, there are no current treatments that reverse the progression, correct? I think that kind of gets at your what you were just talking about.
So one of the great needs in MS is a medicine that remyelinates, that restores or involves the fixing of what's already broke. We do not have that. In fact, there was one medication produced by Biogen which had the promise of remyelination, and unfortunately it was found to be ineffective, and it was called anti-lingo.
We're
And
very
anti-lingo
disappointed.
did not work. We were all so enthusiastic.
Yeah.
We do know that repair takes place naturally in relapsing remitting disease. There are cells in the brain and spinal cord called oligodendrocytes, and they can repair myelin. The problem is that usually the myelin breakdown occurs at a more rapid rate than the oligodendrocytes can put the myelin back into the nerve cells. So this is something that is greatly anticipated. We're still waiting for treatment that remyelinates damaged nerve cells.
And I think that speaks to a couple of things. That's why basic science research is so important. Sometimes people don't appreciate that research that's done in a test tube is really important, because that can lead to the development of new molecules that can be used as treatments. And then also the importance of having different groups and different populations participate in clinical trials, so that we can see if these medications can be effective or not. And what a lot of people don't appreciate about clinical trials is that actually you get followed really, really closely, and you have access to medications that may not be available yet to the general population. And you usually have access to some of the best experts in the country, if not the world. It's not for everybody, but it is an option for people to consider. So I'd like to go to one of the other questions, and I'm going to give this to you, Dr. Williams.
Sure.
It says, do you think that removing gluten and dairy, coffee helps reduce flare-ups?
You know, so there's a lot of question around what causes MS flare-ups. You know, as far as we know, it is kind of a random process, right? You know, we don't know of anything that you can do to make a flare-up happen. I have a lot of people that ask questions about stress. You know, in some cases, if someone has an infection that's severe enough, it can make them have a relapse, but generally it causes what we call a pseudo relapse, where the symptoms temporarily worsen and then improve after that condition is removed. You know, so I have a lot of patients who ask me about certain diets. Certainly, you know, my recommendation usually is there's nothing wrong with trying different things with your diet to see if it may symptomatically make you feel a little bit better or improve other parts of your function. But we just don't have evidence that, you know, eating a certain diet can actually decrease the risk of you having a flare-up. But certainly we do know that if you come up with a treatment plan with your physician and you're taking a medicine, we do know that those medicines do decrease the risk of flare-ups.
And what about vitamin D?
Yeah, so there's a lot of talk about vitamin D with MS, and Dr. Rothstein can chime in. You know, sometimes it's the talk of our Congress and our meeting and everything's about vitamin D. The next year, nobody wants to talk about vitamin D. We certainly know that vitamin D has immune functions. And so we generally recommend that people have normal or above normal vitamin D levels, and their doctors can check those and they can do supplementation. You know, but certainly I don't necessarily recommend that everybody across the board take vitamin D just for the heck of it. And I don't know if you have any thoughts about that, Dr. Rothstein.
Well, we do check vitamin D levels when we draw blood in patients with MS. And if we see that the vitamin D level is less than 30, between 30 and 100 is the normal range. If you see that the patient comes in with a level of 15 or 20, we recommend that that patient be given supplemental vitamin D because, as you mentioned, it is a central part of the immune system and it's necessary to keep the immune system healthy. And so I think deficiencies in vitamin D are uh, should be treated. But if you have a vitamin D level that's a normal range, I don't think you need a supplement. I don't think there's any evidence that having a higher level, if it's in the normal range, is beneficial.
Mhm. Dr. Williams, tell us about your practice's approach to taking care of people with MS. I mean, in the name of your practice,
Yeah.
it sounds holistic. Can you tell
Yeah,
us
it
more?
is. It is, so I really look at, and I just actually did a podcast talking about this earlier about how do you take care of the whole person. I think that MS is a disease that not only affects every part of a person, but affects the extended parts of a person, their family, their care partners, their friends. And so I look at MS not just from a treatment standpoint about what medication we need, but I focus a lot on mental health because that certainly affects our physical health. I focus a lot on support systems. I focus a lot on education, and I focus a lot on empowerment. I think one of the most difficult and saddening things for me as an MS specialist is when people come to me after they've suffered so much and had severe disability because they just didn't know to ask questions. They didn't know that they could seek another opinion. They didn't know how to kind of arm themselves and educate themselves so that they could get the best care possible. And so I'm kind of on a one woman mission, so to speak. But, I think that that's so important. So I want people to understand what's going on, understand why we're doing what we're doing, and also be empowered and educated so that they can advocate for themselves or their family members and care partners can advocate for them, not only in my clinic, but in other healthcare settings as well.
Well, certainly, I'm an academic educator. I used to run the residency program for internal medicine for 15 years. And I would say that we're not that great at educating people. And I think that just within the healthcare system, so there's a lot of room to go there. And I think that some of the stereotypes are still there. And so unless those of us who educate the younger generation have our own information upgraded and updated, we can perpetuate stereotypes for a very long time. I think also, when you do come from either minoritized or marginalized groups, this issue of advocacy is really important. But, when you're not feeling well,
Right.
it's going to be very hard to advocate. So
Absolutely.
I always tell people, take a friend along or a family member along. We know that, for example, when people are diagnosed with cancer, you only hear the word cancer and then you don't hear anything after that. And then I think another thing I've noticed with patients, they are very reluctant in general to get a second opinion.
Mhm.
And this is what I say. When you're going shopping for a car or shopping for a dress, how many different stores, how many different outfits do you try on?
Exactly.
This is your health. And I can say, and I know, I'm sure I can speak for both of you, none of us get offended if you seek another opinion.
I don't.
And yet people are like, well, I don't want to hurt their feelings, or it's like, this is your body, this is your health. If you're not getting answers, go elsewhere and talk to other people, other advocates, if you don't have the energy. And then I think another aspect, because you said, women, Black women are more impacted. Sometimes women were last on our own list.
Absolutely.
Right? We're taking care of family, we're taking care of work. There are all these competing priorities that make it difficult. So for the men in our lives, make sure that you are asking about the women that you love to make sure that they're taking care of each other. Certainly this is true in some of the other campaigns around breast cancer screening. But, we have to advocate for each other. and education of not just the clinicians or the individual patients, but people who have the role of sort of health education. So health ministries in churches and other places of worship. Those are very powerful groups, or other places where we congregate, when we can congregate. Oh, which brings me to another question. I kind of flew out of my mind and then it came back in. What about the COVID vaccine? Is it safe for people who have MS to get the vaccine?
Absolutely. It is critical that our MS patients get vaccinated. There are some recommendations in those patients who are being treated with medicines that influence the B cell activity. These are medicines like Kesimpta and Ocrevus that you wait 28 days between your last infusion and or injection before you get vaccinated. There should be this gap. With the injectables, the older injectables and the oral medicines, there is no necessity to delay getting vaccinated. But I would say that if you're not going to get an infusion for 6 months, you can certainly get your vaccine straight away. You just want to have that 28-day gap between the time you get your infusion or get your injection and when you start getting vaccinated.
And Dr. Williams, is there any evidence that one vaccine is more effective or should be avoided or preferred?
Yeah, so not to our knowledge, not so far. I mean, certainly, obviously, this is a learning progress. It's an evolution in progress. Every time I say a statement about COVID, every time I give a talk about COVID, I say, this is subject to change. Maybe
Right.
tomorrow, maybe next week, I don't know.
Right.
But certainly with the evidence that we have now, the most important thing, as Dr. Rothstein said, is for people to get vaccinated. So if you have the opportunity, you know, we hope that people would not pass up the opportunity trying to wait for this certain vaccine, because we don't know what will be offered in what area. But if you have the opportunity, please get vaccinated.
And this is considered a chronic disease. So this actually puts you ahead of the line. And I think we're now vaccinating people who have chronic diseases.
Absolutely.
So a couple of more questions that came through the chat. One of them is, somebody's had MS for 26 years and testing the gray matter. Besides your practice, do you know if there is testing currently going on in other places? This person is actually in Miami. Where can people go in general for some of these newer technologies, as the one that you mentioned, Dr. Rothstein?
Well, there are a number of different techniques. The one we use at GW is called Neuroquant, but there's another technique called Firefox and Synex and MS Metrics. These are all techniques which use an automated way of analyzing gray matter in the brain. I know that we've been using it here at GW for the last decade, and Hopkins and Georgetown in the last 2 years have started using it as well. What I would do is to check with the radiology department, usually at a university, although here in the DC area, both community radiology and Washington radiology offer this same service. So what you're looking for is a technique called voxel-based morphometry, which does this type of analysis. And this has been my research distinguishing primary progressive MS patients from relapsing remitting patients. And there are steep declines in the primary progressive patients in their gray matter compared to MS. And let me just point out, because I found it very interesting, for any patient who's having cognitive impairment, I've been looking at this technique. And
Mhm.
we are finding a large number of COVID patients are experiencing cognitive problems. They might have delirium, they might have memory issues. I have a woman who had a relatively mild case of COVID. She had shortness of breath and a small drop in her oxygen saturation. And she wasn't hospitalized. She wasn't given oxygen. She didn't need a ventilator. But when she got home, she knew that there was something wrong with her thinking for two reasons she expressed to me. One was that she was supposed to mail a package to someone a few days after she had been tested, and she couldn't remember her home address.
Oh, my goodness.
Described how her family uses different colored washcloths when they take their bath, and she couldn't remember which was her color. And what I found in that patient and one other patient doing this Neuroquant testing, they had very selective damage to the cortical gray matter. And I
Wow.
think it would be a very interesting thing to try and study other
Mhm.
patients exposed to COVID or
Mhm.
having these types of cognitive
Yeah.
complaints and doing a Neuroquant analysis to see whether the same kind of pattern of destruction is happening in their gray matter
Yeah.
that found in these two
Well,
patients.
I have to tell you that I can think of a few patients that I can send you
Mhm.
because we're certainly seeing it. We just have like a half a minute, and I mean, this has been fascinating. I feel like we could talk for another hour. Dr. Williams, you mentioned your podcast.
Mhm.
Can you please type the link in the
Sure.
chat? And then
Absolutely.
where should people go to learn more? Because as you said, this information is rapidly being updated.
Mhm.
Is there an MS site that either one of you would recommend?
So I would definitely recommend looking at the National MS Society's website. They did release some guidelines discussing COVID and COVID vaccination and release some recommendations. I also recommend that your neurologist is your partner in healthcare and also one of your greatest resources. So, any decisions that you make concerning your healthcare certainly should be discussed with your healthcare team, but the MS Society has some valuable information and recommendations.
So while you're tapping that in, Dr. Rothstein and Dr. Williams, I mean, this has been really fabulous. You certainly educated me, and we're getting a lot of great feedback from our chat. For people who have missed this, or if you want to share this webinar with others, it's actually going to be posted on our website, as are all of the Rodham Institute Impact Speaker Series. And I think since COVID, actually, I think this is maybe going on our 42nd or 43rd. We've had a lot of information. We really want to say thank you for joining us. You've done a wonderful job. Dr. Rothstein, I think I'm going to send you at least 2 patients, one with COVID and one maybe with the gray matter issue. Dr. Williams, thank you so much for joining us. You are a Georgia peach. You're wearing the
Yes,
color
ma'am.
of a Georgia. Thank you both so much for taking the time out tonight. I really appreciate it.
You're welcome.
Absolutely. My
All
pleasure.
right. All
Thank you
right.
for having us.
Take care now. Okay. Bye-bye.